Thank you very much, Gordon, and thank you for inviting me to talk today, particularly here in Manchester. I'll go on to my first slide. I work quite a bit in higher education, and this is a professional CPD-rated event, so we better have some intended learning. I'm not going to read through that. Hopefully my slides will be around for you to see later on online. But I think the key issue today is for us to get you to think about what is sepsis. How do you think about diagnosing or considering and diagnosing sepsis in your particular environments, and what the population challenges may be? What is your action that feeds into population health? I'm going to spend quite a bit of time on that because it's not something that we probably consider enough in sepsis. And then very briefly touch on the opportunities that new diagnostic markers may have to drive precision medicine in this field. And as Gordon said, NICE have a particular interest in this. I do quite a bit of work for NICE in diagnostics, and it's very important that you understand that anything I say today is a personal view. I'm not here representing NICE. Much of the work we're doing hasn't been reported yet, and I will allude to the public domain documents as they arise in my talk, and I have no conflicts of interest in this field. This is a pathological diagnosis. If only our patients came with this written on them, we'd be okay. It's not the best diagnosis, but it is the one that's at the heart of the 2012 International Sepsis Guidelines. So sepsis is a systemic, deleterious host response to infection, leading to, as we know, severe consequences potentially for our patients. And the patients that we need to identify for early intervention are those with the most severe end of sepsis. And I'll come back to that, and the other speakers will come back to that later on. Perhaps what this definition doesn't do is capture the breadth of how heterogeneous this syndrome is. Of course, there is no single host response. There are many host responses. There will be genetic undertones to this, and clearly environmental factors and time factors that make this definition oversimplistic, but it is the one that we work with. Now, I went back 12 years to when I was first appointed a consultant in the NHS. And I was asked to give a talk, "Dear Sirs, is this sepsis?" And this was the slide I had in that talk, and I make no apologies for using this slide 12 years on, because of course the world has changed very little, although we'll hear later how the world may be changing. So the diagnosis of sepsis is really at the heart of the difficulties here, that we're told that a patient in our hands who is slightly unwell by a series of measures may or may not have sepsis based on our opinion about whether they've got an infection or not, because of course, and particularly in the surgical patient, it is often very difficult to objectively document infection. And so this is one largely of opinion. And one of the difficulties in this field is the real absence of rapid, specific markers that can identify patients that are going to benefit from therapy. And I could stop the talk there because really we haven't moved on much further. But I'll attempt to move on. So I think we can agree that sepsis, as just defined, and using those definitions, is a very high sensitivity a diagnosis. Yes, it is highly likely that if you use that framework, that you will find people with sepsis. But unfortunately, you're going to find lots of other patients, and herein lies the danger. So you'll have patients that don't have sepsis, and particularly in your surgical setting, may have conflicting or competing diagnoses that are very important, have their own time-critical pathways, such as tissue ischemia, reperfusion, and infarction, which may be treated as infection incorrectly. And so one can see that we have some real difficulties here. And of course then also the overuse of antimicrobials, and I'll come back to that shortly. Now, Gordon alluded to a study that was led here in Manchester, and Gordon contributed to it, and some of you in the audience may have contributed too, and I thank you for that. It was funded by the NIHR HTA to look at this whole field. It was focused very much on new emerging diagnostics that I'll briefly mention later on. But as a byproduct of this, we did a little bit of epidemiology, and I'm just presenting some here. These results will appear in an HTA report in a few weeks' time, so I hope that may be of interest to you. But although it's embargoed, I don't think there's any problem in showing some of the epidemiology, which makes the point, and there are plenty of other studies that make this point, that in a large group of patients in hospital, many of which are in surgical pathways, we can suspect sepsis using the framework I've just described, and then we can really critically have a look at this afterwards using a series of prevalence definitions, and if you do that in an independent way, half your patients haven't got sepsis, although they were treated as such. So this is, these data are pretty typical. So just moving on from that, I think there is a responsibility when faced with a patient who is sick and undifferentiated, that as clinicians, we may reasonably want to put them in a sepsis care pathway. But we've got to consider very carefully whether that's the correct pathway. And secondly, whether the exposure to broad-spectrum antibiotics, antimicrobial therapy, is the right thing at a population level. And I'm not going to apologize for taking a sidestep in the next two slides, just to remind us of the current crisis here. Some people say this is a little overstated in the UK, and I would agree, but this is a global public health problem. And I would agree with Sally Davis that if we don't take great caution here, that we may be faced with an inability to perform routine surgical procedures, perhaps not in our generation, but in future generations. So this was a report that was led by Liam Donaldson in his retirement. I did a lot of work over in Switzerland with the WHO and really identified that we've got a real global health concern in terms of the overuse of antimicrobial therapy. It was suggested that a whole raft of things should occur, and I've highlighted rapid diagnostics. It's not the only thing that will contribute to improve care. Political commitment, and Ron will talk more about political commitment, is crucially important. There's no doubt our Chief Medical Officer is on board, not surprisingly, that I suspect she speaks very closely with Liam Donaldson, and she has really driven this, as you will know. Perhaps for us in surgical and surgical critical care, the data suggests we're doing quite well actually with things like MRSA bloodstream infections. We've had very good implementation programs, and I think we should be congratulated in the UK and the NHS for making big inroads in there. I think we're attempting to control clostridial superinfections. I think increasingly our problem here, certainly in the bloodstream, is gram-negative infections and the emerging resistances associated with those. Now, it's still only 10 to 15% of relevant strains in the gram-negative spectrum that will show evidence of multi-resistance, and that's a little variable. So it's not a big problem, but if you go to the Mediterranean countries, it is of course much greater. And you may be treating patients that are being either repatriated or are from those regions. So the NHS is not free of risk in this regard. And so most of us will treat our patients, our undifferentiated patients with sepsis, assuming that they've got multi-resistance. And so that's a real problem for us. What do the Surviving Sepsis campaigns say about this? This is the 2012. Well, frankly, we're not interested. Although, this is a global problem, we believe sepsis is so important that really we acknowledge it, but we're not doing anything about it. And I have some sympathy with that, as long as we're identifying and treating the highest risk patients. And we'll hear more about that later on. Now, this is obviously leading to a significant public health global challenge, and my view when we're faced with public health problems is go to population health experts, and many of you will know Muir Gray at Oxford, and he talks a lot about high impact, high value interventions, whatever they are, whether they're surgical or otherwise. And he's got this sort of mantra, which has been around for a long time, about the sort of law of diminishing returns. If one has a healthcare intervention, perhaps surgical, and introduces it into populations, one would hope we introduce it into populations that will benefit, so those at the highest risk. And so benefit increases very quickly as we do more interventions. But of course, as we get better at it, we tend to spread it. It perhaps becomes a bit cheaper. We spread that intervention, and eventually the benefits wear off. But you've got a fixed harm rate here. Maybe a low-level harm rate, it may be well documented with that intervention, but of course the more you do, the more harm overall to the population is occurring. And so the overall risk-benefit has a point of optimality. And I would argue that the use of antibiotics in our patients, and particularly in low-risk sepsis, fits this beautifully, that at the moment we're sat over here well beyond the point of optimality. And so one of our challenges is really to come up with strategies to operate at that point of optimality. So at the moment we're over here. To come back in this direction, we need very good rule-out strategies. We need to be confident in our negative diagnosis. Clearly we don't want to overshoot, because we could harm patients significantly by undertreatment. So what we need to avoid that is good rule-in strategies and be confident about our positive, our ability to detect patients with low false positive rates. And so it's a nice construct to think about how we should operate and whether this should be tests, clinical risk stratification, or a combination of the two. I think this is what we've got to think about and what we've got to move towards. Now, I'm just going to briefly remind us why the rule-in is really important. The rest of the talk, I'm going to talk about both sides of this curve. I'm going to start by making sure we try and rule in patients and get that the benefit arm of the curve, and then we'll finish off by considering the rule out. Why do we want to rule in? Well, it's pretty simple in that those that are going to benefit, the sickest patients, there's a very clear dose-response curve with appropriate antimicrobials. You leave it hour by hour, your patient has a much greater chance of dying. These are observational data, but I don't think any of us are minded to do any randomized controlled trials in this field. Murphy may challenge me otherwise, but there you go. It's pretty harrowing. Kumar's led a lot of this observational data. If you don't know, it's worth having a look at. People often forget the Kolev paper, which came in 1999, which is about getting your antimicrobial strategy correct. So you should have good surveillance, and then your approach to unselected patients based on your previous surveillance should be intelligent. Because if you get your choice of antibiotics wrong, it's a disaster. So I'm not going to spend too much time on this, because Ron will talk about this further, but NHS England, led and advised by Ron, has come up with what is a pragmatic rule-in strategy based on clinical science. So rather than using the sepsis definitions and construct that I mentioned earlier, that we build on something that looks a little bit more like an early warning score and to identify severe sepsis and septic shock. I'm not going to talk any more about that, but I think it's an interesting pragmatic development which you can find at the UK Sepsis Trust site, which helps you at the bedside think more carefully about identifying those patients who are going to benefit most from intervention. I'll briefly touch on blood culture. Part of the sepsis care pathway is to get blood cultures and any other appropriate cultures early, and preferably before antimicrobial therapy. Now you might say, and many of my colleagues in intensive care may say, well, what is the point of doing blood cultures? Firstly, they come late in the care pathway in terms of the results. Secondly, they're invariably or frequently negative, and when they're negative, we don't believe them. So we're looking for the occasional positive result, and it hardly contributes to care. Well, I would disagree with that. I think a positive blood culture is very important. I think there is plenty of evidence that it can be brought into stewardship programs, and certainly in our own hospital, we use our cultures very effectively to limit broad-spectrum antimicrobial exposure to our patients. It also provides the crucial surveillance data that you need to act responsibly in an emergency situation. So I think they do have value, but as a time-critical rule-in test, a bit useless. What are the sepsis guidelines say about this? Yes, do it, and for those reasons. There are fairly draconian statements about the use of host response biomarkers, so the C-reactive protein, procalcitonin has a particular relevance in this area, and really not recommended as first-line rapid diagnostics, certainly in isolation, probably a bit useless actually. There are new emerging technologies where we can find pathogen DNA in human samples, and particularly blood, without the need for culture, using PCR technology, and we can do that very rapidly. And so there's a whole big piece of work going on around the globe at the moment, driving these non-culture rapid diagnostics. The last set of guidelines said we don't have enough experience. So we have more experience now since those guidelines, and this is the first NICE slide. It doesn't belong to NICE, I'm just identifying that NICE is looking at this whole question at the moment. You can see they're PCR-based technologies, they're designed as alternatives or complementary to culture, and are laboratory-based at the moment, but there are a lot of technologies being developed that may come to point of care. Now, the available ones to the NHS are listed there. We've looked very carefully at the Roche technology. This will be published in June 2015. It is embargoed at the moment, but there'll be no surprises about that compared with what's known about this platform. Mervyn probably will mention Iridica next. His group, in collaboration with European partners, have led on an industrial study, and it'll be interesting to see when that's reported how this compares with our HTA. And I think I could probably predict how that's going to turn out, because I think these technologies broadly are similar. It's just about how they work and their pathogen spectrums. Sepsis test is a small German technology with very limited evidence. NICE are currently looking at this. The evidence base is developing, so the guidelines will reflect that, and that will be reporting in March next year, so worth watching this space. The last few slides is about rule-out. So I'm not going to go through this. It's pretty obvious why we want to develop rule-out strategies to protect our patients from harm and to get them into the right pathways. Okay, so this is a really tricky area from a research perspective, because to have a high-quality rule-out test, particularly in surgical patients, is going to be difficult, particularly in the setting of sterile tissue injury, when almost certainly you're going to have all sorts of inflammatory cascades triggered. So this is a major research challenge, but is ongoing. A number of us in this country are looking at this challenge, and others globally. Clearly, and it is feasible. I'm going to allude briefly to two papers. If you're interested in this, go and have a look at them, both in thorax this year, one in January and one in April. The first one was led by John Simpson in Newcastle, and we've collaborated with him to help him with this. And it's about the development of nosocomial pneumonia in patients, and particularly surgical patients within the intensive care unit. And these are notoriously difficult diagnoses to make, and John's led on some elegant work that shows us that the absence of a simple inflammatory biomarker rules out the condition, even though you suspect it clinically. And that's a nice piece of work, and we're currently engaged in an RCT funded by the Wellcome Trust, a multi-centre, to see if this has clinical effectiveness using that precision medicine approach. Clearly, this involves getting lung fluid and is quite interventional. We've just published from our own group in Manchester, translating these ideas into breath. So we're able to monitor some of these responses in the breath of our patients, and we've got to, through feasibility and proof of concept, and we're now moving into our first diagnostic studies, looking at whether we can do this non-invasively, so watch this space. The current evidence suggests that culture can't rule out, and in fact, probably the non-culture techniques are going to struggle in this regard as well, but our reports will delineate that. The final little bit is about, well, can we use rule-out strategies in terms of trajectory, so to contribute to stewardship? So the other thing that NICE are really interested in is, can we use biomarkers in these complex settings to help us stop antibiotics? This is a slide of the pro-rata study, probably one of the better studies that's been performed in this field, a multi-center French study in the Lancet a few years ago, and you can see that the proportion of patients remaining on antibiotics over time is much less in a biomarker-guided intervention arm. It's a nice study this. You get about 4 days of antibiotic saving. So in terms of overall exposure to patients, it might be interesting. We're looking at this in NICE. The report of this has been written, so I know the results. It's currently within a number of stakeholders for review, and this will be reporting in a few months' time in terms of the use of procalcitonin in the NHS, and I would recommend that you have a look at that when it comes out. Ron's going to talk more about red flag sepsis. I think it's a pragmatic step. I think it fits nicely into the talk I've just given. What I would do, if there are no red flag signs, I would watch that patient very carefully and think about the differential diagnosis. I think there's a very significant challenge about how we support that approach with biomarkers. In terms of red flags, as we sit here today, I would act. There's no doubt about that. Perhaps some of the challenges here within rule-in is about finding the pathogen, getting your quickly, getting your antimicrobial approach correct, and thinking about de-escalation. Please do stewardship. The final slide is going to blow us all out of the water, and it's led by our next speaker, and he's asking the question, is any of this relevant anyway? But he would, wouldn't he? Thank you.